Now, the three mechanisms, or three possible mechanisms as to why this is possible. So, this slide is then explaining to you, take a look at the words and sentence in bold here, three plausible explanations for the absence of pitting edema. Have I placed enough emphasis on the fact that maybe that you're not going to find pitting edema in your patient? I hope so. This is called aldosterone escape. You're paying attention to this graph that I just went through. And it's a fact that in the middle there, an experiment that is mimicking CON, in which your blood pressure, no doubt, is going to be elevated, even though you're getting rid of your sodium at diuresis. This, ladies and gentlemen, is called aldosterone escape. You see that? Returning excretion of sodium to level of intake. Here, once more, what then happens to your effective arterial blood volume? More you reabsorb your sodium, increase effective arterial blood volume. Next question, pay attention. What happens to your hydrostatic pressure in the peritubular capillary? What happens to hydrostatic pressure in peritubular capillary when you have increase in effective arterial blood volume? Increased hydrostatic pressure in the peritubular capillary. So now it's resisting reabsorption. What happens to filtration fraction? Good. It decreases. Are we good here? Let's continue. The three possible effects or explanations for the absence of the pitting edema: pressure natriuresis, and read the whole thing, results in sodium in the urine from inhibition of proximal reabsorption. Why? Because of decrease in filtration fraction. Hence, I spent so much time attempting to explain to you how important it is for you to know that increase in hydrostatic pressure of the peritubular capillaries is going to then inhibit reabsorption, resulting in a decrease in filtration fraction. Next, there could be an increase in ANP. How's that occurring? Increase in volume? Sure, with Conn syndrome. Next, are you going to dilate the atria? Sure you will. And what are you going to release? Called atrionatriuretic peptide. A possible, plausible explanation. Is it relevant for you? Yes, it is, because you need to know ANP. Big time. And that ANP will do everything in its power to do what? Atrionatriuretic factor. What's natri mean? Sodium. Uretic means diuresis. Number 3, decreased concentration of thiazide-sensitive sodium chloride cotransporter, possibly. The two big ones are the first and second one. This is called aldosterone escape, thus giving you a plausible explanation as to why you wouldn't have pitting edema. What is pitting edema, by the way? What is that? Transidate or exudate? I'm sorry, what did you say? Good. Transidate. Be confident. You're right. Good. That transidate is what pitting edema is. Only. What does that mean in terms of protein? It's protein poor. But it's full of what? Sodium. Isn't it? It's protein poor. Transidate is. You're absolutely right. But do not forget, it's full of sodium. So if you don't have sodium even accumulating in there, you can't have. What does pitting mean? You put your thumb or whatever on that the inflammation, and you take off your finger, and oh my goodness, look, there's my thumbprint. Well, I like my thumbprint. No, not so much good for your patient. But anyhow, can I be any more dramatic? That's pitting edema, isn't it? Let's continue. Major collecting duct, where are you? Way down the collecting duct. We're just about to do what? We're about to enter my minor, major calyx. We're about to enter my collecting duct, and out you go into the ureter. Divided into, inner and outer, so be it. Responsible for a little bit of sodium reabsorption. We talked about all this in terms of aldosterone. Let's now move on to water. It's a major site of free, stop there, free water. What does that mean to you? You remember the difference that we talked about and you have discussed with physiology and in terms of free and obligated water? Allow the name to speak to you. An obligated water is one in which the water has been attached to some type of sodium or solute. Okay? Where are you? With the obligated water, this was the water that was coming in from the loop of Henle, and it was moving through the thick ascending limb. What then happened to the thick ascending limb? You ripped the sodium potassium 2 chloride away from the water. And now, let's just call it a mother, and I'm just going to be dramatic here, the mother and the baby. You're ripping the baby away from the mother. Come back. But no, it doesn't want to. It's the child is free now. So that water is completely free of any type of attachment. That's free water. This is the diluting segment. That free water continues through the distal convoluted tubule, comes down the collecting duct, and ADH has an opportunity, if needed, to then reabsorb that free water only. What do you know about antidiuretic hormone? It only reabsorbs water. But there's a huge exception in which the ADH can only work by removing that urea as well. Overall summary, we've talked about every single segment of the nephron, from proximal through descending limb, through the loop, through the thick distal collecting duct, aldosterone in great detail. We put in all the major drugs. I just wish to ask you a couple things before we end our lecture series on this note. Bartter syndrome, alphabetical order. What are you hitting first? It behaves like a loop diuretic. It works in the sodium-potassium 2 chloride channel. It works to disturb the concentrating ability of the nephron. You have hypercalciuria that you do not have in Gittleman. Bartter syndrome may have hyperprostaglandinemia, increased prostaglandin, management, indomethacin, big time, potassium-sparing drugs such as spironolactone. Bartter. If you go to Gittleman, we're working on the thiazide sensitive. In fact, the gene, sodium chloride, thiazide sensitive gene or receptor. And Gittleman syndrome, much more common than Bartter. And with Gittleman, some of the biggest differences is with Gittleman, you have an issue with diluting ability, but not so much concentrating ability, correct? Next, as far as calcium is concerned, you don't have hypercalciuria. With Gittleman, you have hypocalciuria. So those are some major pathologies we talked about there. And down by the collecting duct, we talked about Addison's and Conn's and dealing with aldosterone. Full picture, ladies and gentlemen, of the nephron from beginning to end, the physio, the pathology, the management. You know this. You are solid.